Hello, everyone, and welcome to In Conversation with the Liver Transplant Team. My name is Penny Lesage, and I'm a living liver donor, and I will be moderating today's discussion. Just a reminder that you can submit your questions on slido.com by using the event code PM4, and that today's session is being recorded and will be available on the Center for Living Organ Donations YouTube channel. Before our panelists introduce themselves, I'll just give you a little bit of my backstory here. In 2016, my husband went into end-stage liver failure, and we live in Manitoba. We have a wonderful healthcare team based in Winnipeg. So the Manitoba team told us it was time to consult with Toronto General, which was our closest option for a liver transplant. Shortly after that, my husband was placed on the transplant list, and we were introduced to the idea of a living donor. When I first brought up the idea to my husband about being his living liver donor, he refused. But due to rapid progression of his liver disease, he eventually had no choice but to accept my decision to apply. We had 2 young children at the time, so it seemed like things were evolving quite quickly. And I flew to Toronto for assessments, and all the testing and assessments were completed within about a 3-day period. On July 27, 2016, I donated 68.2% of my liver to my husband. And I'm happy to report that as of today, my husband is healthy and strong, and that we are both enjoying an amazing quality of life with our families. So that's a little bit about me. And yeah, let's meet our panelists. Maybe we can start with Cheryl, if you can introduce yourself, please.
My name is Cheryl. I am a registered nurse and a transplant coordinator in Toronto. I started in the program 19 years ago and have been in my current role, which includes liaison for referring physicians and evaluating patients for suitability and eligibility for liver transplant. Been doing that for the last 16 years. So,
excellent. Mo?
Hello. So I'm Mo. I'm a registered nurse as well. I am one of the pre-liver transplant coordinators. So basically, I manage the patients once they leave Cheryl's capable hands and get on the wait list, then they are mine until they get transplanted or otherwise. And I've been in transplant for 13 years, but in this position for about 6 minus 2 for mat leave.
Yeah. Excellent. Thank you. Chantal?
Hello, my name is Chantal. I'm also a registered nurse, living donor liver coordinator at Toronto General. So I take care and coordinate the care for all live donors from the application process through their whole journey until they get to surgery, and after as well for 3 months. I've been a nurse for 15 years. I've done many different things. I've been at Toronto General for 1 year only so far. My past includes pediatrics, med-surg nursing, and case management. Thank you.
Great, thanks. And Shauna.
Hi there, my name is Shauna. I'm one of the post-liver transplant coordinators. So I'm one of the 5 nurse coordinators who follows patients after they've had a liver transplant within Toronto General. My background is nursing experience in transplant. So I worked on the transplant unit for 5 years as an inpatient nurse. And then I've been in this role for approximately 3 years as a post-transplant coordinator.
Excellent. Thank you. Can you guys please walk us through the liver transplant process? Maybe if we can start with Cheryl and Mo. You guys can start us off. That would be great, because I think you guys are the first point of contact.
Sure. So I'll start by just mentioning some of the process. So the referral process for our program, we receive referrals from not only our province, but across Canada for recipients. So they're referred from an external specialist, hospitalist, family physicians, and those are all triaged then by myself and by the transplant physicians. We receive them many different ways: phone, fax, mail. Sometimes patients call, and we facilitate that referral process as well from their physician. The patients are then seen in clinic. Due to COVID, it has encouraged us to see more patients virtually, so OTN, which has helped a lot of patients access our program who otherwise would not be able to travel due to illness or other. And then for patients that are seen and deemed appropriate to start a transplant evaluation, then we go ahead with that. So the evaluation consists of testing, which includes some blood work, some heart tests, some lung tests, some imaging of their abdomen or their liver, and then some consults with some of our transplant specific teams, so our social workers, our anesthetists, and our transplant hepatologists as well. Depending on the outcome of that, sometimes additional testing is required, and most of the testing we do is in line with other provinces as well for transplant eligibility. So speaking to that, Trillium Gift of Life Network is the provincial organization responsible for organ and tissue donation in Ontario. They're also responsible for facilitating allocation of deceased donor organs. Similar to the program in Nova Scotia, which is Legacy of Life, or Transplant Manitoba Gift of Life, just a couple other provinces, so they each have their own. They set out the eligibility criteria, which has been developed through collaboration with the transplant programs, so physicians, surgeons, and nursing. It discusses some of the diseases that liver transplant is indicated for, some of the absolute contraindications that would make it unsafe to proceed with liver transplant, and then they assist with the allocation of organs for deceased donors. Trillium Gift of Life is not involved in the living donor process, as that is a program specific and unique to Toronto General. Part of the eligibility, part of the allocation process includes something called a sodium meld. And for anyone who's heard of transplant or spoken to any of us, you will have heard that term. And it's a sodium model for end-stage liver disease. So what it is a model that looks at how sick a patient is and how needy they are of urgent transplant. So that's calculated based on blood work. It helps to guide the allocation of deceased organs. It also helps us to guide decisions around surgical booking for patients with living donors. The purpose of it is to assist in reducing the deaths on the waiting list, to provide equitable access for patients, and to ensure the optimal use of deceased donor organs. We are part of a provincial wait list. So in the past, we shared with, or we had a separate wait list for liver transplant with the London program. We now share a wait list which provides increased access to patients who are waiting. The MELD score is a number range between 11 and 40, with 11 being less ill and a MELD score of 40 being gravely ill. So we do look at that when we allocate deceased organs and when we look at booking surgical dates for living donors. It's updated regularly. It requires patients to complete blood work on a monthly basis. At times, patients are granted what we exception exception points. So these exception points acknowledge that blood work does not necessarily define a patient's illness. So sometimes where this is not reflected in blood work, such as patients who have liver cancer, patients who have genetic disorders, or patients with primary sclerosing cholangitis with multiple episodes of infection, sometimes between these episodes can be relatively well. So it's a complex process looking at the patient, not just as a number and a place on the waiting list, but monitoring their medical status on an ongoing basis and ensuring that we are providing access to transplant, whether it be a living donor or deceased donor, when the patient needs it. So Once the patients have been through that process, they are discussed as a team, surgical representation, anesthesia, our transplant hepatologists, nursing staff, social work. We decide as a team to accept patients on the waiting list, and then they are handed over to Mo to the next step of, I tell them they graduate to the next step of their journey, where Mo picks up and waits with them.
So once they
Sure.
come on, oh, sorry, go ahead.
Yeah, I just had a quick question, Cheryl. How long does that process typically take? Is there a general kind of timeline, or?
So a standard evaluation takes anywhere from 4 to 6 weeks. Some of that depends on how much information is received with the initial referral, and then some of that depends on whether additional testing is needed outside of a standard evaluation process. But on average, we're looking at about 6 weeks.
Okay, excellent. Thank you. Sorry, Mo.
It's okay. It's okay. I always say if you have questions, stop us now and ask them before the time passes. So while patients are waiting on the wait list, so what happens on a Friday, we'll discuss them. My job is to actively list them in the system so that they are now active patients awaiting transplant. And then I call each one if I can, unless they're inpatients, which makes them a little bit different. I call each one to let them know that, hey, they're officially on the wait list. Expect a package to come home in the mail. The package will have a couple of things, housekeeping tips, and I go through that with each patient over the phone. One of the expectations while you're waiting for transplant is that you will continue to do blood work for us on a monthly basis, because as Cheryl mentioned before, your sodium MELD score is kind of dependent on your blood work results, and that can fluctuate a little bit every time you do blood work for us. Sometimes it'll be stable, sometimes it can fluctuate, sometimes it can even get better. So they have to do their blood work once a month, every month for us, unless we want it done more frequently. They have to continue to do their cardiac testing every year to make sure nothing new pops up with age. They also have scans that need to be done on a regular basis, and they can call us to find out when these things are coming up. We also like to keep track of their social supports. By social supports, we mean, who's coming into the hospital with them to take them to their appointments, who's driving them around, who's taking them to their blood work appointments. At points in time, we have discovered that for some patients, these social supports do fall through because they realize the demands on their time and the disruption in their life. They, for whatever reason, sometimes family members or friends can't help them. And so there is a change in the social standing, the social situation. And so, the patient ends up in hospital again. We come to find out that some things have fallen through. So then the social worker gets involved trying to figure out what next for this patient. With regards to how long people wait on the wait list, it is really dependent on your sodium MELD score and your diagnosis. So like Cheryl mentioned before, some of our cancer patients get exception points. And so they can potentially start to get calls 6 to 9 months into their wait time, with potentially transplant happening at the 12-month mark or a little bit later than that. I mean, that's an approximation at this point in time. It does depend on the score. Our score, as Cheryl mentioned before, starts at 11 to get on the list and goes all the way up to 40. Patients who are potentially getting called in for transplant at this point in time are anywhere between 28 and 31. And when you do get called in for a transplant, you can have something called a false alarm, which is where you come in and you expect to get to your surgery. And they tell you, oh, after a certain wait time that the organ is not suitable. So patients do get sent back home without surgery, and this can happen a couple of times. I had one patient, for him it happened 5 times. It was a false alarm, and the 6th time it was finally successful, so they were very excited. But with every false alarm, the patient does get a little dejected, and they call us saying, what's going on? Am I going to get my transplant? The fact that you're getting called in for a transplant means your number is up there, and it has to be a blood type match and a size match. So that is a height and weight approximation as well. Because, for example, if the patient were about 5'2" and the potential deceased donor were about 6'5", you have a size mismatch there. So a very large organ in a larger person cannot physically fit into a smaller body cavity of a smaller patient. So the surgeon, this is a surgical decision at the end of the day. So the surgeons make that decision and they decide who next on the list they can call in that's an approximate size match for the organ. Yeah, I guess if there are other questions about wait times, we can discuss that. But we do try and give exception points to certain diagnoses, depending on whether they have cancer or PSC or repeated episodes of cholangitis with PSC. So our doctors do advocate for some of their patients if they feel that it's necessary. With regards to, sorry, go ahead.
I was going to ask, if patients are on the deceased list, can they still have a living donor?
Oh, yes. We have that as a concurrent option. So if anybody has live donors that are wanting to step forward for them, they have to wait for the patient to be listed initially on the wait list before a donor evaluation can be started. And I always tell patients, if you have somebody, tell them to put in the paperwork, because unless the paperwork is physically given to the donor program, we don't know that something is happening. And while a donor is being evaluated, the patient is still on the deceased donor list, active, awaiting transplant from a deceased donor organ. The only time that that name comes off the deceased donor list is once live donor transplant surgery has been successfully completed. Then they come off the deceased donor list. When I get told that a donor has been found 100% suitable for a particular recipient on the wait list, and there is an OR date already in plan, I speak with the medical team and ensure that this patient's deceased donor status on the deceased donor wait list can go temporarily on hold while we wait for the surgical date to come through. If the surgical date gets canceled for live donation at any point in time, then they can just be reactivated back on the deceased donor list. They don't lose their space or let their slot on the deceased donor wait list. They maintain their standing, and they just get put on hold while we make sure that the live donor surgery happens. And if that happens, yay, successful, then we take them off this list. And if that doesn't happen, then we just switch them back to being active on the deceased donor list.
And do you ever have like the false call-ins, like you had mentioned, like for out of province recipients? Like, do you ever have to call? Are there ever any out of province? Yes, and
yes,
they end up in Toronto and then have to.
We do. I don't know how many times that's happened, but we do have a fair number of patients waiting out in Manitoba for a deceased donor organ. Yes, and if there was a live donor to be worked up there, that the donor program would look after, obviously. But for deceased donor, we have something called Life Flight, which is a company that helps us with transporting these recipients when they get the call to come in for transplant. That helps them get to here. I don't know if we've had any out of province patients come in for a false alarm. I'm sure it's probably happened. We've been doing this for a long enough time, but in my recent memory, I can't think of somebody right now.
Okay. Great, thank you. Just a reminder too to everyone that if you want to submit your questions on slido.com, please feel free to do so, and just use event code PM4. Okay. Chantal, did you maybe want to speak about the donor process at this time?
Yes, I would be happy to do so. So I will continue off where Mo left off. So when a recipient is told that they have been listed and that they are suitable for a live donor, because not all recipients may be suitable for a live donor, then their donors can submit to the office by fax, email, an application and a blood type. The application is found on our website. You can complete it. It's quite lengthy. It asks a lot of medical questions, personal questions, but it's very important for us to know the history of the donor. Blood type also needs to be submitted. You can get this at your family doctor. People who have donated blood will also know their blood type. They're given a donor card, and that can be you can send a scanned copy of that to our office. We can't proceed unless we have the blood type. The blood type on most cases needs to be a match. And at times we get multiple people applying for one recipient. So we could have one donor apply, we may have 50 donors apply. We only can work up one donor at a time, and we will call you if you're suitable to proceed to an evaluation. Now, sometimes people aren't suitable to proceed to an evaluation for many reasons. It could be age. So you need to be between the ages of 16 and 60 years. Body mass index. So this is a calculation that you can find online. There's a tool, you put your height and your weight in, and it will tell you what your body mass index is. Under 30 is considered a healthy, normal body mass index. That does not count for muscle mass though, so please be cautious with that. Anyone with a body mass index of over 35, we cannot start a workup until there's some weight loss. Approximately 10% weight loss needs to occur. If the body mass index is around 33 or lower, we can definitely start an evaluation, but we will also start some weight loss as well, and healthy active living to get some of that off before the surgery. Some other medical conditions that would be an automatic exclusion would be diabetes needing medication, and sleep apnea needing a machine at night, so a CPAP, and that would also be an exclusion. There are other things, but we would talk to you over the phone about some other things that might exclude you. But if you are healthy and between the ages of 16 and 60 and have no major concerns, you can definitely submit your application. And then I review these, all of them, and we will screen you if we're going to move onwards with your evaluation. Now, some donors and recipients may feel a bit neglected or frustrated because they think that we've lost their application or we've never called them. But sometimes we don't contact you because we have someone else in workup. You will receive an email stating that the application has been received, and we will call you if needed. So please try to remain patient. I understand it's very stressful and it's a very difficult time, but we keep the evaluations and they're all in our office, and we will definitely call you if you're proceeding. And when I call you, I will go over the process in general, so you're aware of what you're signing up for. At any time, you can step down. So this is a voluntary process. It's altruistic in nature, so we want people to feel free in their choice. So some people have stepped down because if they're not comfortable. So I go through that. I also mentioned that the recipient and donor team, as you can see, are all separate. And we do that for ethical reasons to protect each individual, and that the donor feels supported with their own team, okay? Now, the first step is to come to Toronto General and have your initial testing, which is going to see if you can be a match, anatomically speaking. And this includes, so a bunch of blood work will be taken, around 16 vials of blood, ECG, which is an electrocardiogram of the heart, a chest x-ray, so we're looking at your lungs, and then an MRI and a CT of your abdomen. And these are really important. So this is going to look at the size of your liver and the health of your liver, and also the anatomy. The surgeons review these images, and we need to make sure that you're safe to proceed as a donor. Unfortunately, only around 1/3 of our donors who go through this initial screening can move on. 2/3 are excluded, and the main reason is usually size or complicated anatomy, which could put yourself or the recipient at risk. And donor safety is our priority. So if you get that call, it's very sad and hard to comprehend, but it is for your safety. Once we know that you're an anatomical match, then we're going to book many other consults with our team members. So surgeon, medical doctor, anesthesia. You might have additional tests depending on your age. We have to do cardiac testing for people over the age of 50 or who might have previous asthma history. So this whole assessment can last 6 to 8 weeks long, sometimes even longer if the donor needs additional tests and consultations. All donors will be supported through a social work and a psychosocial nurse, or psychiatry if needed. They will also meet 2 surgeons to have independent consultation, and you'll have lots of time to have all your questions answered. And I do education at least 2 to 3 times throughout the process, so you're informed and feeling comfortable moving forward to surgery. Once you've completed all your consultations and tests, then we will start talking about a surgery date. And then once that's confirmed, it's exciting. And then Mo connects with her recipient and also informs the recipient at that time.
Great. Chantal, is there a specific diet that the donors should be following?
So there's nothing specific, but we do ask people to be extra cautious during this journey. The stronger you are and the fitter you are before you go into surgery, the better the recovery. So we want obviously healthy eating, following Canada's food guide, and you do need to abstain from alcohol, recreational drugs, and smoking. So that does need to be abstained from, and you have to remain not using alcohol for 2 to 3 months after the surgery. So we have that discussion in the preliminary education session. And then in the future after as well, maintaining a healthy lifestyle and exercise is really important.
Okay, excellent, good. Okay, and then transplant happens. And then we move on to Shauna. Can you tell us a little bit about what transplant looks like and immediately after surgery, as well as moving forward the weeks and months after that?
Definitely. So like I said, I follow people after they've had a liver transplant. So I'm one of the 5 coordinators. We work in a coordinator-physician combination. So each liver transplant patient that stays under our care in Toronto will be assigned to a coordinator as well as a physician, and we will follow you essentially lifelong following your transplant care. In terms of patients who are staying in Toronto, obviously we'll follow you forever. If someone was referred from a hepatologist in, say, Ottawa or Kingston, there might be a period of time, maybe at the 1-year mark, where someone transfers back to local care. Obviously, people who live out east or in the west will transfer back to their local physicians. In terms of right at the moment of surgery, so someone will go into the transplant surgery, and once they are out of surgery, they will either go to an intensive care unit or a step-down unit, where both the patient and the donor will be monitored with a cardiac monitor. They will have invasive lines, maybe a line in their neck or a line in their wrist, and very close monitoring with either 1-on-1 or 2-on-1 nursing care. Obviously, blood work will be monitored regularly, their vital signs. There may be subsequent imaging that is done after surgery. As the care becomes, as someone becomes a bit more stable after their transplant surgery, they will move from a step-down unit to a ward, so a regular hospital unit. And the focus of care will be on mobilizing, optimizing your nutrition, and sort of recovering and getting ready to go home. Once things are stable from a physical perspective and a blood work perspective, patients will be discharged home. And once they are discharged home, my job will be to continue to watch their blood work, probably on a twice-weekly basis for the first few weeks. We were normally seeing people in clinic on a weekly basis, and then every 2 weeks, and then monthly. The world has changed a little bit recently with COVID-19, so we are adapting and doing virtual visits for patients. So people are seen through a virtual platform, either through their computer. We're doing phone call visits. And obviously, when we need to see people in the hospital, we are seeing patients in person in clinic. The monitoring for these patients essentially is blood work on a regular basis, depending on your indication for transplant. So the reason why you had a transplant, there are different protocols that we follow. So for example, if someone was transplanted for a liver cancer, we will continue to do surveillance scans on a regular basis. If someone was transplanted for NAFLD or a fat in their liver, we will do protocol biopsies or fiber scans. So the follow-up care will look different for each patient depending on why they received their transplant, but it will always be coordinated by myself and a physician group. So that is the short version of what happens right after transplant.
Okay. What exactly should recipients and donors expect from transplant? I know myself, I've got this beautiful scar on my body, and like, do you have any points of or any wisdom here that you can share that I know myself, it was very surreal emotionally and physically, because I went in healthy and my husband, of course, was deathly ill. So can you talk a little bit about what to expect from transplant?
Yes, do you want me to go first, Shauna? I can talk about
that's perfect.
Okay, so a little bit about the donor surgery. It's 6 to 8 hours long. It's a major abdominal surgery. So it is a very difficult surgery for a healthy individual to go through. And it includes a 1-week stay in hospital. And you will also be in step-down unit for the first few days and closely monitored, and then transferred to a regular ward bed, and then discharged home usually around day 7. If you're donating to a pediatric recipient, the hospital stay is less, so it's 3 to 5 days. And now in the first week, it is very hard. So I tell donors and I'm very honest and transparent, that it's difficult. Some people describe it as being hit by a bus. Sometimes it's an emotional roller coaster. And other people find it just okay. They'll say it's been okay. So it varies depending on each individual, but it is a scary situation. So it's for a healthy person, and the next day they're in, a step down unit attached to tons of wires with also a central line and a tube down the nose. It's very temporary, a catheter. So for their family members as well, it's very distressing. So I try to teach people to expect that, so they're not fearful. It is all temporary, and it will be removed quite quickly. And by the time day 5 hits, most people are feeling much better. And emotionally speaking, it is very difficult. So there's days of feeling some loss, sometimes some trauma, frustration, or sometimes just so much gratitude that you can't even grasp it. So it's an adjustment to go through, and I like to be by the donor's side to help them through that process, even though I've never donated, but I live through them that way. So it is quite beautiful, the journey from the beginning to the end, and there's some bumps in the road, and it's not easy. And that's why the whole team is here for everybody, because it isn't easy. That being said, when the donor goes home, the first 6 to 8 weeks will be also an adjustment, especially the first month. It's the hardest. There will be pain. There may be nausea. There could be constipation. There can be minor complications like incision pain, incision infection. The incision is 10 to 15 centimeters long, so there will be a scar. And it's just getting back to a normal routine, getting your strength back. So it's slow, but surely people get back to their old self. Some people might even feel off until month 3. Most of the time, people are back at work at 1.5 to 2 months, and the normal complaints are just a lot of fatigue. So just tired, hard to get through the day, but they're able to eat, they're sleeping better, they're working out, but the fatigue can linger for some time. And some people do note mild anxiety and depression around that time as well. And that is normal. And we support them, and we have a whole team here if they need further help with that. And the follow-up appointments, so you have an appointment with the surgeon at 1 month and blood work. And then at 3 months, an MRI is arranged, and to just make sure there's no complications, which would be very rare, but it's just another little safety check, and more blood work at 3 months. And then we send everything to your family doctor. We ask them to follow the donor every year for 10 years to ensure that their blood work is normal, their liver enzymes are stable, their complete blood count is healthy. And that's all described thoroughly to the doctor and the donor. And we're always here to help donors in the future. Sometimes people have a question or a concern, or emotionally they're not coping well at month 4 or 5 for a specific reason. And we're always here to help, and we will refer our donors when needed to whoever they need to see, specialist or general practitioner, etc. And I think that's it for my part.
Is there specific exercise or nutrition after, like, post-transplant?
So for the donor, we just ask no raw meat or raw fish, so things like sushi, just to reduce the risk of possibly getting a bacterial infection. We ask them to eat small little meals at the beginning just to help with digestion and bloating and gas and all that. The gallbladder is removed in most cases for the donor during the procedure. So that can change some people's digestion in the first few months, where they have difficulty with high fat meats or high fat dairy. So we just tell the donor to be cautious and, eat. But if you're craving something, like I've had people say, I just want that, small piece of pizza, sure, go for it. And then exercise, take the 6 to 8 weeks, gently, and then return to working out as before. Just be cautious and no heavy lifting for the first 2 months. But we've had high performing athletes start running, jogging or going back on their bike to train at 4 weeks. Each person's journey is unique, and other people need 3 months. So I don't like to compare, but it's general guidelines. But listening to your own body is really important.
Excellent. Good.
Shauna,
And what
before
about,
you, sorry. I was just going to
Go
say,
ahead, sorry.
there's a piece for the patient with me before they transition to Shauna's care. So whenever we get to that, I'll just comment on that.
Yeah, no, go ahead. Go ahead, Mo.
So when you talk about diet and fitness and nutrition for patients who are waiting for a transplant, we ask them, there's a couple of things that we do nutritionally speaking. One of them being cut out salt from your diet as much as possible, completely preferable. Because salt and water are best friends. Where there is salt, there will be water retention. So my patients struggle a lot with a ton of water retention, and it needs to get drained sometimes every 2 weeks, every week. It depends on how much they tend to collect on board. With regards to other things nutrition-wise, we do try and encourage a higher protein intake diet. Now, that's very difficult for some people because their appetites are they have a lack of appetite, let's put it that way. They're bloated usually, they've got so much water on board, they're finding it hard to breathe sometimes, it's the amount of water. And the water can be like up to 11 liters. We're talking a lot of water on board here. So they can't ingest 3 meals a day. I always recommend don't do 3 meals a day. Break them up. If you can just do like a smoothie or half a cup of smoothie at different intervals in time, do that. Make sure you've got some protein in there. Whether it's lean meats that you go to for protein or vegetarian protein intake, whatever your case may be. I do try and encourage that as much as possible for these patients and trying to stay as active as possible because your fitness level going into transplant, in through surgery, will definitely affect the recovery post-transplant. And this is where I transition to Shauna's care.
So yeah, I think that's very important, just thinking of the recipient. So it's difficult to give a timeline of sort of recovery of what to expect, as every individual walking into transplant has different health complications, health concerns, depending on how long someone has been sick or on the wait list, how much muscle mass they have lost. That will all dictate how fast someone is able to recover. So I think what we try and tell our patients is just to give yourself grace and time, that you were sick for a long period of time, so it will take a similar amount of time to recover. Thinking of post-operative care or just care at home, very similar things. Canada's food guide, there is one diet restriction. We ask people not to have any grapefruit juice or pomegranate, as it can impact some of the immunosuppression medications that they're taking. No lifting for at least 3 months of anything more than 10 pounds, just as your incision heals on both the outside and the inside. In terms of what to expect, so there's a million things to expect after a transplant in terms of there can be complications or bumps in the road, such as things like rejection or infection or surgical complications. But the main sort of focus, or there's such a loss of control probably before the transplant and even after, the main things to focus on are just taking the medications on a regular basis, doing the blood work as scheduled, and just trying to be sort of as healthy and active as you can. And just recognizing that things will take time. And it's probably the worst answer for patients, but everything just takes a bit of time.
Mm-hmm. Good. I have a funny little story if I can share. When my husband, right after transplant, the doctors were telling him, okay, the sooner you can get mobile, the better. That was the message consistent for both of us. And so the doctor had said, start with, because my husband was up. As soon as he could, he was up. And the doctor had said, well, start with 4 to 6 laps around the ward. So he misunderstood. And the nursing team were wondering what's going on. And they said, Rob, what are you doing? You're out here. And he goes, well, the doctor told me to do 46 laps around the ward. So he was aiming to do 46 laps. So it was like, but he was determined, and the sooner he got mobile, the better, and there was no stopping him. So Yeah, it was crazy. Can we talk a little bit about the out of province piece? Like we came in from Manitoba. Is there anything that you can add with respect to, you know, some of the challenges with out of province donors and recipients?
Well, the out-of-province recipients, while they're waiting on the wait list, like their live donor Chantal takes care of, but while they're waiting, they're actually followed by, I can only comment on the Winnipeg patients at this point in time. There's a team out there with a coordinator out there that actually takes care of them on a day-to-day basis. I get updates periodically, depending on, you know, how sick are they? Did they suddenly get admitted for X, Y, and Z? Does that put their status on hold on the wait list, etc.? But they are managed by somebody locally for them. I don't know if there's another, are we looking at Atlantic provinces? There, I don't really know about them. Cheryl might be able to comment on that. But yeah, so there is somebody out there waiting, or in Winnipeg, who looks after their needs. And there is a medical team with a coordinator.
Right.
So we've built a robust partnership with the Manitoba Transplant Program, so that so patients coming from Manitoba, Peggy, as you may have hopefully have realized, is a little bit smoother process. We do offer transplant through our live donor program to patients in British Columbia, in Alberta, most recently from the East Coast as well. So the main thing I can say is if we can secure a partnership with a medical team out there. So whether it's a nurse and a physician, or a physician who's committed to helping us provide that care and minimizing travel for patients, that's something that we're looking at continuing to build across Canada, but definitely have done it quite well with Manitoba. And I think the experience that feedback we're hearing back from the patients, both recipients and donors, I think has been positive in both their confidence in the teams locally as well as our team.
Mm-hmm.
Then regarding the donor, there are two options. They can either have their family doctor start some initial testing so they don't have to travel to Toronto to do the CT and MRI. That being said, there can be delays in certain provinces to get these types of imaging done and completed. So depending on the needs of the recipient, sometimes it's not appropriate, and that would be a discussion we could have on the phone. Other times people directly want to just come here to Toronto and have their testing done, and we would just talk about a week that works for them, and they would come to Toronto and stay and do all the initial testing. The problem is, though, too, if they get excluded, then that is an expense that they're taking on to fly here and get hotels, etc. So that's all discussed in the conversation that I would have with them.
And just to follow up on that, the COVID pandemic has definitely put some changes into some of those travel, the ability or restrictions now for out of province for both recipients and donors. So we're conscious of that. We do our best to minimize the amount of time patients either are have to put their lives on hold to be in Toronto or when they return home. But that is something that's fluid that we're working with, and hopefully will not change too much in the coming months. But that's definitely a challenge with out of province.
Mm-hmm. And how long do donors and recipients typically stay in Toronto after transplant?
Shauna,
so donors will usually stay about a week after they get discharged before they go home.
Yeah, the recipient, it would depend. So it would depend if they came from a hospital and were transferred here for their transplant. Then they might be transferred right back to the hospital that they originally came from. So a hospital to hospital transfer, depending on their status post-transplant. Or individuals will fly home probably in the similar timelines within a week if that's safe for them, or if there are reasons that they need to stay in Toronto longer, that would be discussed with them by the medical team. It's very much dependent on where they're coming from and sort of their clinical status after the transplant. There definitely are indications where some individuals, for example, someone from Ottawa might need to stay in Toronto for a prolonged period of time in terms of a matter of weeks. But it's definitely case by case.
Okay, thank you. Do we have anything else to add with respect to the process before we move on to questions? Okay. Courtney, are we able to maybe look at some of the questions that have been submitted?
Sure. We'll start with this one here at the top. So if you're coming to Toronto from Manitoba for a living donor transplant, is it faster than waiting for a deceased donor transplant in Manitoba?
So I can speak to that. Manitoba doesn't have a liver transplant program. So that's why we have partnership with them. So if you live in Manitoba and require a liver transplant, you're looking at going to either Edmonton or Toronto. The majority of patients do come to us because we do offer living donation, and your wait time for living donation is significantly less than waiting for a deceased donor. Again, dependent on medical status, but
yeah, definitely. I
yes.
concur with Cheryl.
Yes, because as I alluded to, we can do a recipient workup in 4 to 6 weeks, probably less because Manitoba does all of the testing, and Chantel typically could work up a donor in 6 weeks as well. So you're looking at 3 months to transplant, as opposed to potentially 1 to 2 years for a deceased donor.
Great. Thank you.
Hopefully that answers the question.
I think so. Yes. Thank you, Cheryl. So next question here. My son is on the liver transplant list. His brother is a match and he is proceeding with testing. Do you still look for a liver while he is waiting for results for his brother? And if one becomes available, does he still get the call? Had 2 date livers and both have been canceled, told someone else got them. Mo, I feel like this kind of relates to what you're talking about a little bit before. Yeah.
Yes. So while somebody has a live donor going through the evaluation period, and keeping in mind, I'm not involved on the donor side whatsoever, they are still active on the deceased donor list. They are still waiting for a deceased donor to come up with their match, basically. So depending on their MEL score and how high up the list they are, if they are, let's say, in the top 5 for their blood type, because on the deceased donor list, it has to be a blood type match and a size, so height and weight match as well. While the live donor is going through evaluation, they are still active on the deceased donor list. We will still call them in if their number came up.
Great, thank you. So next here, we've been getting a lot of questions recently about paired liver exchanges, but here's another one. Paired kidney exchange or chains seem to be fairly common. Although there have been some paired liver exchanges, what prevents that from being more common? Why are liver exchanges only a more recent event? Do you see that becoming more common and with longer chains in the future?
So I'll try to answer that as best I can. So the kidney side does have a national system in place that's been in place for some time. So they have a registry that coordinates all that. As our live donor program is UHN, our own baby here, we don't have a paired exchange registry yet for live donors. We have done one successful live donor exchange in the past recent years. So we're definitely looking at more resources and trying to get that up and running because people are interested, and that can hopefully reduce some barriers for donating if you're not a blood type match.
Great.
I was actually going to say that there's a possibility. I could be wrong on this one, but I think for kidney transplant, you don't need to be a blood type match. But for livers, you need either a match or a compatible blood type at this point in time.
All right. Thank you. Chantal, I guess this is another one for you. What would preclude someone from being able to receive, I take that back, Cheryl or Mo, receive a living donor organ?
So go ahead.
Sorry. The number one reason that typically a recipient is not eligible for living donation is anatomy. So oftentimes due to liver disease, patients develop blood clots in some of the blood supply to the liver. Sometimes that can become so extensive that it makes it unsafe surgically for the surgeon to remove that much blood supply to get rid of the clot. So that is the number one reason typically we see patients not eligible. The other one that historically had made patients ineligible was if they had had a prior transplant, whether that was from a live donor or a deceased donor. Of late, we've explored performing either a second live donor transplant if a recipient's organ graft fails, or after following a deceased donor transplant years down the road, they require retransplant, and we've explored living donor options again, looking at safety for donor first and then recipient as well. So usually it has to do with the anatomy or the blood supply.
And we do CT scans for any recipient that might have a live donor in the works to make sure the anatomy of the recipient is suitable.
And would you say that it's fairly common that most, or would you say that most recipients are able to receive a living donor organ?
I would say maybe 1%, if that, in my experience of recipients have been ineligible for living donation.
Okay, interesting. Next question here. I understand that it can be emotionally difficult for potential directed living liver donors to be declined because they are unable to help a loved one who is suffering from a life-threatening illness. How do you help support individuals in these situations?
I can answer that. So it's multiple people involved would be involved in this. So our Center for Living Donation, who is doing these wonderful webinars this week, they have a wealth of education and help our recipients and donors through the journey. So we have outreach coordinators who can assist individuals with some of the questions they may have or some of the barriers and try to find some solutions for them. Also, if the person had submitted an application, I do call those individuals and explain the reasoning why. And obviously, if they have questions, concerns, or need support, reassurance, advice, I'm always there to offer that. But it is a difficult thing, and we try to find someone else in the family or community that can help, so they don't feel so sad about the situation that they're in. And I always say to people who can't donate, there's lots of other things that people can do to help the recipient. It's not just being the donor. You can be the support person. You can help the family with meals, driving them to appointments. There's so much help that's required for individuals needing a transplant. It's not just being a donor. It's being a great support person and family member through a difficult time. So.
Yeah, absolutely. Thanks for that, Chantal. So the work that the Living Liver Donor Team does is amazing. Do you have any most memorable moments working with recipients and donors?
I'll let Cheryl talk, or Shauna talk with recipients, but for donors, each individual is so unique and each story is so unique. And obviously I'm not going to comment on specific situations because that would be a breach of confidentiality, but to just be a part of their life during this very difficult time, but also amazing time, it's a privilege. And it's just so nice to see, siblings donating to siblings, parents, children, family members, anonymous donors who are coming up to donate and they don't even know the individual. So you see such beautiful stories and learn a lot about their past and what made them want to do this. So it is very special.
I think from my side of the equation, when I have a recipient that gets a live donor after, well, for example, there was one who'd been waiting for 4 years, and finally there was a live donor match. So extremely grateful. They're so thankful to us for enabling this to happen, like for allowing the situation to come about instead of waiting and waiting. I had a recipient donor combination. It was a family, so a couple, similar to yourself, Penny, but it didn't pan out for them because there was an issue last minute, and so it got canceled. And then literally within, I want to say 2 weeks of that, the number came up for his deceased donor organ. So he didn't get taken off the list. He got made active again. And he got called in for deceased in about 2 weeks. And the wife was so grateful because she felt terrible that her own donor surgery had been canceled. But it was for a medical reason, and there was nobody could account for that. So, yeah.
Cheryl, Shauna, any memorable moments working with recipients and donors?
I can say in general, I had an experience, patients that prior to Mo coming, I was managing the waiting list as well. And some of these patients unfortunately waited, 3 or 4 years. So you build a relationship. And they would get the call for transplant, and I would see them coming into clinic a month later and say hi, and they would ignore me. And I was very offended until I spoke to some people, and they said, well, they associate you with being unwell. They're not unwell anymore. They're living their life now. So it was, I stood back and I looked at it and I thought I'm it's a privilege, as Chantal alluded to be involved with these patients at their most vulnerable, and to be trusted by them, but also then to be able to step back and see them. It's like you're raising your kids. You got to let them go. So with the patients, I feel that way sometimes, where you build those relationships and then you see them move on, and it's a great feeling.
Yeah, so I work in the post-transplant side. So after someone's been fortunate to go through with their transplant, and I think some of the most memorable moments are at the beginning, you're helping individuals navigate the complications or the concerns and the physical, mental struggles that everyone's going through. And then just over time, your conversation kind of just switched to those things being in the background. And in clinic visits, you're talking about grandchildren and golfing and activities that individuals are doing. So I would say the most memorable moment is as things switch and your transplant becomes something that's just in the background for you.
Nice. That's a really good one. Thank you, Shauna. So we're coming up on time, but we'll just try to answer these last 3 questions really quickly. So why do you assess one potential donor at a time? Chantal?
So we assess one potential donor at a time to make it fair and equitable for each applicant and recipient. As I mentioned before, some recipients may receive only 1 application, others may receive 50. We only have a certain amount of resources at this time, so we have to be fair and make it safe and fair for everyone. So that's why.
Great, thank you. For out-of-province patients, what supports do you provide? Financial, accommodations, travel, etc.
So for the recipients, unfortunately, Ontario does not offer reimbursement or financial accommodation for this. We have had some feedback from Manitoba where recipients are able to receive some reimbursement or some support. Unfortunately, a lot of that has to do with recipients doing fundraising, reaching out to their communities, reaching out to their religious communities. And being able to travel. So the surgery itself, any of the hospital care is covered interprovincially, but unfortunately the cost of flying here, staying here, and meals or parking is not something that's covered at this time.
And for the donor, the social worker will be able to discuss with each donor these possible supports. So there is a Trillium Gift of Life program that does some reimbursements for donors who are donating to a recipient with an Ontario health card. There is also some Manitoba supports as well. And this will be described to you. It's not a lot of money, obviously, but it does cover certain things like accommodations, flights during the surgery. And you're just supposed to keep all your receipts, and that can be submitted after you've gone through the process. And social work will go over in more detail with you if you have any questions or concerns. Though you can also find a lot of information on the Trillium Gift of Life website, and you can go there and it'll explain everything to you, the reimbursement program.
Sounds good, thank you. Just because we are coming up on time and I want to give Penny the last few minutes just to close out the panel. For these last 2 questions, we will respond to you on Slido, so stay tuned for the answers later on.
The next one's answer is really easy, by the way.
Oh, do you want to just do it really quickly?
They all get swabbed when they come in, and you get the results in 24 hours. And if it's positive, it has to be moved. The surgery has to be moved.
All right.
Yep.
So this final question will be answered later on Slido. Thank you.
Thanks, Courtney. I guess just in closing, if we could quickly go around our panelists again. I'd just like to give each of the panelists an opportunity to share what motivates them to do their job. If you could just quickly weigh in on that. Maybe Cheryl, if you don't mind starting.
In addition to everything that I've already said, all the positives of transplant and being involved in the patients and families, unfortunately, not all of the patients who are placed on the waiting list do make it to transplant. Right now, if you go to the Trillium Gift of Life website, I believe 20 to 25% of patients do not make it to transplant. They die while waiting. That's a significant number of patients, and people often ask me how I cope with that. The way I cope with that is that 75% of my patients make it to transplant, and then I get to see that process. So that is what motivates me, is to make that 25% smaller.
Great. Thank you. Mo?
I enjoy nursing. This is my second round at school, and I love it, and I wouldn't give it up for anything in the world, except maybe my kids. But I think that, along with Cheryl, knowing the mortality on the wait list, and since November of last year, unfortunately, I was asked quite a few times to come down to our ICU to be at the bedside while the patient passed away. So the family members asked me to come down, and it hurts. It really does hurt. But I look to see the patients that get successfully transplanted and make it through to the other side to be cared for by Shauna and the rest of them. And I do check in to see how they're doing once in a while, especially if I have favorites. Like the young ones tend to be favorites, just because they're really sweet and they look scared all the time. Or you have like people with whose families you've connected and built a bond, and you want them to do well. You want them all to do well. So I always try and see, hey, how's so-and-so going? And yeah, it's fun to see that side.
Wonderful. Okay, how about you, Chantal?
So what motivates me is just learning every day. As I said, I've only been here a year, so I still have a lot to learn. And I look up to all these wonderful people who've been here forever to help me and work with the amazing multidisciplinary teams, so the surgeons, the doctors. Everyone is just so positive, and really they put so much effort into this job. It's not just a job, it's a passion, and it definitely shows. So that motivates me to keep learning and be up for the challenge, and be one day, been here for, say that I'm here 10 years, but yes, that's what motivates me.
Excellent. And Shauna?
So I think what motivates me, my entire nursing career has been on transplant. So I used to work on the floor, inpatient, when individuals are waiting for transplant or they've had one. And I only had this limited view of what transplant was, the sick individuals who are in the hospital. And now I have this breadth of a view of life after transplant. So I think what motivates me is just to sort of help people navigate. I have 400 patients, so things that I go through day to day are common to me, but it's the first time that this patient has had their transplant and navigated it. So just helping them navigate this entire course and getting to a point where their liver transplant is something that's in the background as opposed to the forefront is definitely what motivates me.
Wonderful. Great. Well, a big thank you to our panelists today. Those who have submitted questions and everyone watching at home, thank you very much. We really appreciate your participation in the ongoing discussion about live donor liver transplant. Just a reminder to check out the final session in the In Conversation series, In Conversation with Caregivers. It's moderated by Heather Lannon. It's tomorrow at 2 p.m. And then finally, we're exceptionally grateful for the generosity of our founding supporters, Astellas Pharma Company, the Kearney and Cahill families, and a big thank you to Toronto General and Western Hospital Foundation for their continued support. So thank you all for tuning in. Take care.